the guidelines that we follow, okay? Because we, not only are we follow the guidelines for the JRC DMS, the DMS is our governing body. The KHEP, they're the ones that give us our accreditation upon the JRC's recommendation. If the JRC says that they're not, don't give them a license, then the KHEP will not give us a license. Okay? That's how it works. KHEP is the president, the JRC are the police. Okay. Oh, I got the wrong one. So what happens is, I just submitted the site survey. Okay, so they're gonna look at it for the next year. JRC will come in next summer, either August or September. And then they'll inspect the office, make sure we teach what we're supposed to teach, and y'all are one-on-one education in the clinical sites, look at our lab, and then they'll report back to KHEP and say, yeah, give them a license. Okay, and then that's when we go through our 5-year accreditation again. Okay, but we have to do that because there's certain protocols that we have to follow, and a protocol is how things are done. Okay, not only do we have the JRC that's mandating what we do, but we also have the American College of Radiology. The American College of Radiology is how the radiology departments get their license, and I think that's a 5-year accreditation also. Okay? So, as a student and as a sonographer, it's our job to take care of the equipment. If you find that the cord has been run over and it has a split in it, you report that to your DCI, your designated clinical instructor, okay? Or tell your sonographer, and then she has to follow the proper channels, okay? Because you cannot have an instrument that could possibly cause any type of danger to yourself or to the patient. And if you have cords showing, like last year we had to take one of our probes out of commission in the lab because one of the students got cut because the face had kind of sunk down inside the mount, and it had a sharp edge on it. And so when they went to turn the transducer, they cut one of the students and didn't even know that it was like that, you know, until an accident happened. Didn't cut her bad, it was just a scratch, but it's still, ow, you know, what was that, you know? So, and that's part of the inspection that we want to do. We want to take our hand over the face of it and make sure that that doesn't happen, that the transducer has gone down. The crystals, if you have a crystal that's gone out because you dropped it and didn't say anything to anybody, then you have a black streak down the middle of your imaging, and so that has to be fixed. The cord could come separated from the transducer head. That's a danger, so we need to report that because they only come in and inspect our machines here at the school annually. They come out annually and do that, okay? So if you find out that your image isn't as good as it used to be on your machines, you want to be sure that you call Biomed in, and what they'll do is they'll give you a loaner and give you something to work with until that one can be fixed. You've got to realize that some of these transducers cost as much as $30,000. So we have to be very, very careful of how we take care of them, okay? when you examine, all of our machines here in the lab are at 100% power because they're all donations and they were taken out of circulation for various reasons. So all of them are at 100%. So I'm not gonna sit there and talk to you with the transducer live because it's just sending heat waves, sound waves down into your body in one place. Because we sit there and we talk for 15 minutes, okay? Well, if you're gonna talk, just hit the freeze button. Just hitting the freeze button will make your transducer not active, okay? That's considered an overexposure to the sound waves. Now, they don't know of any type of damage that has been caused, but you gotta remember, it's not even 50 years old, hardly, that they started using ultrasound in the hospital settings. So it's not really old enough to have much history behind it as far as the bio effects that ultrasound can cause, okay? So whenever we look at our instruments and our instruments are the machine, because you're not gonna run a machine if the keyboard doesn't work right, because you can't type. And so report that to biomed so it can get fixed as soon as possible. You know, if you accidentally spill a Coke on it, don't try to hide it. Just say, I spilled a Coke. Blame it on the patient. I spilled some Coke on the keyboard and it needs to be checked out. It's a lot easier to check it out right after it's happened than it is for it to sit for any length of time. And we've all dropped transducers. We've all made those mistakes with our machines. But the only thing that makes you good is if you report it, you know, you're only as good as your machine anyway. And so you have to take care of your machine. Okay, what is this called? Minimal exposure. What is that called? Anybody?
Don't use the transducer.
Yeah, but it has a name. You're close. Alara. Okay, as low as reasonably achievable or something like that. Okay, and that goes with talking to your patients with the transducer live. Or as students, we tend to go over the same area over and over and over and over, you know, to the point where their skin is just like, it hurts. No, it hurts. Especially if you're going through the ribs, because that area never gets touched.
Yes, it is.
Mm-hmm. Yeah. Okay. When you're doing abdominal work, the patient is usually fasting. Another name for fasting is NPO. Nothing in your mouth after midnight. Okay? If you do a patient that they ate, send them away and have them come back before your shift is over. Okay. Every exam that we do it in sagittal and we do it in transverse. Okay? We never document or measure anything unless we see it in two planes. Because there are pathologies out there that when you turn on it and it disappears, you know what it is. But we're going to teach you all that. Okay? So never measure anything in one plane. Never, ever, ever. Okay? So when we're looking at the liver, we look at all three lobes, right? Correct? Okay, what are those three lobes?
Left, right, and caudate.
Left, right, and caudate. Okay? So when we look at the left hepatic vein, what is that separating? Left from medial lateral. Correct? Because it's not until I get to the right hepatic vein that I'm left and right hepatics. Okay? So gallbladder's the same. Everybody knows because we talked about the protocol for the gallbladder in lab, and we've already talked about it in clinic. Okay? You never take a shortcut. If you find pathology, you still do the protocol. If you find pathology, you still do the protocol. Okay?
Can I ask, what's the shortcut example?
Oh, I see a gallstone. Oh, I'm just gonna take sagittal and transverse the gallstone. I'm gonna measure it, do color, and I'm done. No. You do the protocol.
Yeah, you have to do the step ladder, the impedance, and supine too. Right?
Correct. You always do supine and you always do decubitus. Okay? Always. Okay. What is that called? Using probe pressure to assess for painful gallbladder. What's that called? Murphy's. That has to be on every gallbladder you do, whether it's negative or positive. If it's negative, you put negative Murphy. If it's positive, you put positive Murphy. But if it's a positive Murphy, you get someone else to come and assess it. Okay? If you're already a sonographer, you get a radiologist. If you're a student, you get your senior sonographer. Okay? So, imaging the entire length of the biliary tree. What's that? What's the biliary tree?
The hepatic ducts with the bile ducts, and it comes down to the duodenum.
Okay.
Yeah.
Okay, so a lot of times, unless I have pathology, I'm gonna only see that hepatic duct right there at the porta hepatis. Remember that image that we all try to get? And we're gonna start working on this tomorrow in lab. Most of the time, this is the only thing we're gonna see. This would be common hepatic duct, this would be common bile duct, this would be the main portal vein. Okay, so, what is this? Portal triad. Which one is the hepatic artery?
The one on the
The
left.
one on the right.
On the right.
If I'm looking at it, it's the right ear. Okay?
But it's the
If I'm looking at it, it's always this ear. Okay? But really, it's the left ear because the left side is always on this side. Does that make sense? I don't want to get you confused. Because the picture, this is always the left, this is always the right. But if you're looking at it, it's the right ear. Is the easiest way to remember it. Okay? And that's because I've cut it right here. That's where I've cut it. Okay? But we're gonna start working on that tomorrow in lab. So that way each of you get one day. Pancreas. What o'clock does the pancreas sit in the abdomen? If I'm thinking of the pancreas as far as a clock, where is the head of the pancreas pointing?
9.
Huh? No, it's not gonna be 9 o'clock.
Between 7 and 8.
Yeah, it's gonna be between 7 and 8, because this is 9 o'clock, and it's gonna sit like this. Okay? That's how it sits in there. Okay? Now, if I wanna look, if they say the patient has a lot of gas, and I wanna look at the head, what am I gonna do with my transducer? I'm gonna heel toe it, and I'm gonna look at the head. Okay? If I wanna look at the tail, I'm gonna heel toe it, and I'm gonna look at the tail. Okay?
we do heel toe.
Heel toe.
Yeah,
If you wanna look at the head, if you wanna look at the toe.
and we push to be under
Oh,
the
you
dermis.
can't push too much, cause they might have pancreatitis. And especially, we can give them pancreatitis if we stay over their pancreas too long. We can actually aggravate their pancreas, okay? Okay, what's if I see the SMA, am I gonna go superior to the SMA or go inferior to the SMA for the pancreas?
Superior.
No, I'm gonna go inferior.
Yeah, because the pancreas right here, that's me right here.
Yeah,
The picture that she
yeah,
got yesterday.
exactly.
You have a picture?
Okay, so here is my pancreas. Here's my SMA. Remember the donut?
No.
I love those donuts.
No.
I can't take a bite of them though, I gotta pop the whole thing in my mouth. And then somebody talks to you and you've got. I don't even buy them, cause I can't put them down, okay? Okay,
Oh.
okay, yes.
I
We
have a
have this picture, but the SMA is showing on the inferior.
I know the SMA is super.
SMV.
SMV is right above the SMA and then SMA is.
No, this picture that we had it in the class. Look at,
Is it in the book?
I don't know, who gave it to us?
Oh yeah, it's FSA and FSB.
That's the SMV. We're talking about the SMA.
So we're gonna get SMV هنا وهذا SMV.
We have both of them.
هذا
on this.
Yes.
هذه SMV.
Because remember, okay, let's draw it again, because it's on the registry.
تو طلع SMV يطلع من فوق.
Getting confused. Everybody look.
Uh-huh.
Splenic vein leaves the spleen, runs posterior medial to right here. The SMV travels up and meets the splenic vein. Now I have what we call the confluence. I'm like this, right? If I turn my transducer clockwise, it goes into my liver. Now it's called the main portal vein. Once I dial it in, main portal vein. My main portal vein is like this. So here it is. It's gonna go through the head of my pancreas. And I'm gonna see pancreas here, and I'm gonna see pancreas there. Because it's going through the head of the pancreas.
inside?
It goes through it. Think of the pancreas as a bridge or a tunnel. The CBD tunnels through the pancreas because it also meets the what?
About that.
The duct
Come on, boy.
no, that's down here.
Oh, that's,
What's it here?
the W word.
Worsen.
What word?
I know it's difficult, but y'all are gonna get it. I am not gonna give up. And you're gonna hear it a million times. Okay, you're gonna hear it a million times. Okay. Yes. Mm-hmm.
Here the SMA is in here.
Yeah, this is the SMA. No, that's not pancreas, that's stuff in the stomach. This is the pancreatic head.
This is the vein and this is the
هاي الصورة من ورا.
Oh, is this a sick pancreas? Oh, yeah, it's
لا ده
calcification.
شيء اللي
يعني
فهمه.
الساعة ما طلعت.
This is,
هذا السكند
إيه.
this is a splenic vein, this is the SMA. Yeah, the SMV, we don't see it.
هذا هو ورا
SMV.
مو
So the splenic vein is superior to the pancreas. So if I'm looking at my aorta, I'm gonna see my aorta at the liver, right? Because I've got my splenic vein, my liver. What else comes off that? There's 3 branches, and then right below that is the SMA. Sometimes it's the same trunk. So that's way up here. Okay, so depending on where I'm hitting this, yes, I would see the SMA inferior to, because of the way I'm hitting it. Okay, because they're trying to show you without getting this to shadow what a chronic pancreas is going to look like.
So, Ms. Shepherd, you're saying that the SMA is anterior to the pancreas? Or
No, the SMA is posterior to the pancreas. The SMV runs medial, posterior to the pancreas.
the SMA is over the pancreas or behind?
It's gonna be one of our landmarks for the pancreas.
Yes, but it goes upper and the upper.
You're not thinking 3D. Okay? Okay, let's look at it crosswise. Okay? Here's my aorta. This is my aorta. This is my spine. Okay? So my aorta is gonna travel up with my spine because of my lordosis. Okay? What's up here? The celiac axis. What's right below it? SMA. What's all of this area? Liver. Okay? What's right posterior to the liver? Stomach. What's posterior to the stomach? Pancreas. Okay? So if I see the SMA, I know I'm too high in the abdomen. I need to travel down. From here to here. I'm traveling superior to inferior abdomen. Okay? So if I see my SMA, I know I have to go inferior on the patient's body. And not only am I going inferior, I'm going counterclockwise. Okay? Because I'm trying to see the whole pancreas. And if I want to see the whole pancreas, it lies from 8 o'clock to 2 o'clock. Or from 7 o'clock to 1 o'clock. Okay? I don't want to get y'all confused. Got it? Everybody on the same page? Okay. Okay. Now, when I'm looking at the pancreas, I'm also making sure that the duct of Wirsung is not dilated. Okay? That measurement is 3 millimeters. Okay? It should never be dilated. But because the splenic artery runs superior to the pancreas, the splenic artery runs superior pancreas on the way to the spleen, there's lots of blood vessels Because not only that, there's all kinds of arteries coming off, feeding all of those, that other stuff that's in there. So turn on your color. If it's a dilated duct, you will not have color. Got it? Okay.
If it's a dilated duct, it will not.
It will not have color. It's just stagnant fluid. Okay. Not only that, but when we're in that pancreas, aorta, all kinds of pathologies happen. From here to here, millions of pathologies. Not millions, but a lot. Okay. So here's my aorta. Here's my pancreas. Oh, that's a sick one. Okay. When we are looking at that area, we're also looking around the aortic nodes. Peri-aortic nodes. If you see a homogeneous mass next to the aorta, that's lymph adenopathy, meaning your lymph nodes are enlarged following the aorta. Abnormal. Okay? But right now, you're not expected to see it. By the time you graduate, you're expected to see it. Okay? Especially if you're following up on a CAT scan and the CAT scan report said peri-aortic lymphadenopathy. You better find it on ultrasound. Okay? So, if I have fluid around my pancreas, I have fluid in my Morrison's pouch. Morrison's pouch is where? The right kidney, the liver. This area right here is called Morrison's pouch. I have ascites. I have too much fluid in my peritoneum. Okay, that's called ascites. If it's not too much, my body will absorb it. If it's too much, it's going to have to be drained. Because what happens, it builds up the abdominal pressure. And so when I breathe, my lungs can't depress the abdominal pressure, so I'm SOB. What does SOB mean?
Short of breath.
Yeah. I looked at you. I saw you were fixing to say
Nej, men
Okay.
det skulle gå och nämnde.
Shortness of breath. Okay. When I'm also looking at the pancreas, I'm looking at the head of the pancreas to make sure that my common bile duct is not dilated. Where's my common bile duct? It's in the head of the pancreas, not superior, that's the GDA. It's inferior. Inferior head of the pancreas. I still can't believe they cloned a dog. Isn't that amazing that they would have that much extra money?
And where at? Here in Texas?
Yeah, where? Yeah. She lives in Texas, so. Okay, so you haven't learned, have y'all learned spleen? Did y'all learn spleen with the kidney? Okay. Spleen is really easy. It's just sagittal and transverse. But it's one of the hardest exams we do because we give